4 years of her career primarily treating upper extremity injuries in both acute care and outpatient settings. After moving to Huntsville, she joined the TOC team and has been completely focused on treating upper extremity orthopedic and trauma injuries. She is part of a strong team of certified hand therapists who treat quite specialized upper extremity injuries that require skill in orthotic fabrication and manual techniques, including the FRAMS method of tool-assisted soft tissue mobilization, along with various other manual therapy techniques to maximize patient recovery outcomes. Nicole's interests in the field include hand trauma, including tendon and nerve injuries, management of arthritic hand patient, both pre and post-operative, treatment of overuse syndromes of the upper extremity, and treatment of the athlete. Additional skill of serial casting applied to patients with neurological conditions who have developed spasticity and receive Botox injections. Welcome, Nicole.
Thank you. Can everybody hear me? All right. Well, thank you all for staying. I know this has been a long morning and it's almost over and people are trickling out. But anyway, I'm very honored to be here to speak among the panel of people that we have seen this morning. I'm a lot of esteemed physicians. And then there's me, the therapist. So I will do my very best to keep you all engaged, and hopefully I can provide you all with some really useful information to really help your patients. All right, so obviously we're getting off the tilt-a-whirl of hand stiffness. When I was little, I loved the tilt-a-whirl. Such a fun ride. Now as an adult, I don't find hand stiffness very fun. So I kind of want to impart to you all some suggestions on how to best prevent it and then treat it when you do see it. All right, so stiffness, all right, big long definition. Sorry, I'm not very savvy here. Okay, so it's usually the term reserved to describe the physical property of matter whose close molecular structure makes it rigid, okay, stiff, resisting deformation, okay? But stiffness in the hand is different. It's not increased rigidity of the tissues themselves. Rather, stiffness is a constraint created by cross-linking, that's abnormal process, by the previously elastic or moving tissues into a configuration of collagen fibers. All right, so my big thing is prevention, okay? Timing of everything and prevention is key. Oh, that was strange. Okay, so as Benjamin Franklin says, an ounce of prevention is worth a pound of cure. Remember that, an ounce of prevention is worth a pound of cure. Our goal altogether should be to prevent as much stiffness as we possibly can, okay? Knowing that it's always going to be inevitable, but we need to prevent as much as we can. It's a team-oriented approach. It's not just me, it's not just surgeons, it's not just doctors, it's you all. You all are the liaisons between your clients, your patients, the surgeons, and myself. We have to be a team. We always just assume that every patient will develop stiffness, okay? I just always assume. If I see someone in the grocery store and they have a splint on their hand, I'm probably going to approach them and ask them what happens. Because if I can even give them a sliver of just something to prevent hand stiffness, I'm going to do it. It's a little awkward, but I do it frequently. All right, so this is my life in a hand therapy clinic. Mrs. Smith, can you make a fist for me? This is what happens a lot, okay? This patient, she had a proximal phalanx fracture of one finger. One finger. Look at her hand. Look at that. That hand is way more difficult than you all will ever know. That to me looks like should have been weeks of therapy, and now it's going to literally be months of therapy. It's important to understand that some patients' tissues will be very hyperreactive to trauma, okay? We all know that. And some patients' tissues are hyporeactive. So we all need to understand that we don't know what someone's tissues, what their histology is like. So we have no idea what's going to happen as they heal from these injuries. So I am always suspicious. I'm always worried that someone's going to develop a problem. So I like to prevent them. There's really no way to know which patients will fall into what. So always assume they will get stiff. Always, just always assumed. If you have a patient that has a very anxious and guarded personality, realize that they are a ticking time bomb, okay, for developing hand stiffness. and the nasty word of complex regional pain syndrome, or RSD. When you have a patient that has a finger fracture and they walk up to you like this with their arm cradled and they're walking like their hand is made out of glass, be wary and be very, very scared. Okay, so why is the hand so susceptible? I mean, it's just a hand, right? People like to walk in and say, oh, I just broke my finger. It's just my hand, right? And I'm thinking, oh, if you only knew. All right, so, oh gosh. So we have 27 bones in the hand, 27. 8 of those bones are the wrist, with ligaments going all over the place, okay? 27 joints, 34 muscles, 100 ligaments and tendons, many blood vessels, 3 major motor nerves. Oh, and by the way, each finger, one finger has 6 muscles controlling its movement, okay? There are 3 intrinsic muscles, meaning they start and end in the hand, and there are 3 extrinsic muscles, meaning they start and end in the forearm, okay? So that's a lot. You might think it's just a hand. Why are they having so much problem? This is the problem, okay? So the big thing is maintaining a delicate glide of all the structures, okay? So you've got all these tendons, all these nerves, all these bones, all these ligaments. We're like puppets. Everything has to glide. If the gliding is impeded, you won't be able to bend your fingers. If you can't bend your fingers, you don't have strength, you don't have functional use. If you don't have functional use, well, guess what? You can't go back to work. That's our goal here, right? Returning to work, okay? Hand and wrist trauma inherently causes edema and scar, okay? There's not a lot here. You got bones, you have tendons, you have muscles and nerves, especially with a crush injury or a very traumatic injury, you're gonna have more problems. There's not a lot to it, okay? Early controlled motion, okay, and proper positioning during healing is paramount to maintain this delicate balance. Injured tissue, okay, is replaced with immature collagen. Well, okay, collagen's cool, right? I take collagen supplements. They're supposed to make you younger, right? Not in a hand. Collagen makes up scar, okay? And that interferes with the reestablishment of gliding structures. No glide, no fist. No fist, no function. No function, no work, okay? One wound, one scar. They all heal together. One continuous mass. There's no differentiation between the structures. Miss Smith comes in, you ask her to make a fist, you should get this, you get that. The structures are not gliding, okay? So that just destroys the gliding planes. It's a disaster. Okay, so what's our course of action? Okay, we know what can happen. Okay, well, what do we do about it? Assure proper positioning of the injured hand and wrist during the healing phase. It's easy. It's very easy. It seems like it should be easy, but poor positioning happens all day, every day. Prevent unnecessary immobilization of the uninjured joint. If you can, if a joint isn't injured, don't immobilize it. If you take your patient or your client to a doctor and they immobilize an uninjured joint, do something about it. Be an advocate for them. Ask them, well, why did you immobilize their entire hand and extension if they just broke their small finger proximal phalanx? It happens, believe me, and you guys have a big part in advocating for your patients. Oh, and assure that creases of the hand are respected during immobilization. All right, so I don't get along very well with palm readers, right? I've been to New Orleans. People ask me, hey, do you want to get your palm read? And I say, what are you talking about? All it tells me is where the anatomy, that's where the joints move. That's why we have palmar creases, right? Nothing mystical about it. It's literally anatomical. So when you look at a hand, you need to assure that your patients are positioned correctly, post-operatively and post-injury, okay? Respect the palmar hand creases, all right? The notable creases, the distal palmar crease, okay? The distal palmar crease is there because it tells you where you get MP or metacarpal phalangeal joint flexion, okay? Proximal interphalangeal crease right there. It allows for PIP motion. So basically the ability to bend your fingers. The thenar crease there, so you can bend your thumb. Really important. 50% of the function of your entire hand is your thumb. Okay, common errors. that drive me insane that I deal with all day, every day. Cross the distal palmar crease. Okay, I would say 90% of off-the-shelf orthotics, okay, they cross the distal palmar crease. Why is this a big deal? Because if you can't bend your MP joints, the ligaments shorten and you lose the ability to bend your MP joints, okay? Crossing the PIP, that's typically occurs in a wrist fracture. So you want to put one of those little simple off-the-shelf splints on. You think it's great, it's comfy, it's cushiony, cool. Okay, the bone's going to heal. Well, guess what? If it crosses that crease and they can't bend their MP joints, when they come in to make a fist for the therapist, it's going to look like this. And it's going to take me months to get that mobility back. Okay. If you cross the PIP joint, PIP crease while you're immobilizing a proximal phalanx fracture. So if you cross that crease for some absurd reason, then the patient can't bend their fingers. Well, that's a problem. Okay. If you position the MP, so these joints, the big knuckles on the back, in extension for proximal phalanx or metacarpal fractures, okay, it causes shortening of the ligaments, okay? So basically, if the ligaments shorten, the patient makes a fist like this, and they can't bend their MPs. It's not a fix of weeks, it's a fix of months, or it could go on to another surgery called a capsulectomy, okay? All right, these are really fun slides. So this is an example of very poor positioning in an off-the-shelf TKO brace, which they probably use this to either treat a metacarpal fracture or a proximal phalanx fracture. Okay, do you see that hole right there? That's so it can be used on the right hand or the left hand. I call that not one size fits all, but one size fits nobody. One size fits nobody. If one of you all sees one of your patients or your client and they have this on, get them out of it as soon as possible. Take them back to the doctor and say, what is this? Or take them to a different doctor, or say, I want a hand therapy referral so we can put them in a custom splint and turn weeks, months and months of therapy into weeks, okay? It's smart. The problem is if the MP is an extension, remember what I told you, if you position the MP in extension, the collateral ligaments are going to shorten and then they can't bend their fingers. I mean, I don't think I would want that. I know none of y'all would as well. The PIP joint crease, obviously, is crossed, and that'll cause unnecessary joint stiffness. So this patient's going to come out with what I call a ping pong paddle hand, okay? Not a hand for functioning, but if you want to play ping pong with it, it's great. All right, so if they came to my clinic, this is what I would make them. I use a low temperature thermoplastic material. I draw a pattern that's custom made for them. I throw that in hot water and I custom mold it to their hand, okay? So this is a custom fit ulnar gutter. Notice that those metacarpal phalangeal joints are placed in mid-flexion, actually a little bit more, around 60 to 70, and I left the PIP and the DIP joints free. So the MP joints are on stretch, so they're not going to get a contracture, and their PIP and DIP joints can move, so guess what? They don't get finger stiffness, okay? So this orthotic, if it says ulnar, is used to treat ring finger and small finger. That's the ulnar side of the hand. Okay, so this is a radial gutter, meaning it's used to treat the index finger and the long finger. Okay, so in this, I might treat a mid shaft or a metacarpal head fracture, or even better, a proximal phalanx fracture. Yeah, you can immobilize someone in this for a proximal phalanx fracture. This can be conservative management, meaning no surgery. This can be someone who has plates in their finger, and this can be someone that has pins sticking out of their finger. Because this plastic is moldable, we can actually mold it around pins. So they can have pins sticking out of their finger, and we can mold it around so it'll protect the pins, but allow them to move the uninjured joints. Seems like a win to me. This is an ulnar gutter, meaning the ring finger and the small finger, okay? So here, once again, we were treating a proximal phalanx fracture of the small finger. The MP joint is flexed, so no contracture, and the PIP joints can move. It seems like a win to me. Much better than the black one size fits nobody. All right, So here's another really great one. This happens all day, every day to me. So look at this beauty. So this is a wrist splint. This is a very expensive wrist splint. See that little thing on the back clicks up like a corset? I'm sure you guys have seen those, right? If it's put on correctly, they're okay. If it's put on poorly, it's garbage, okay? This is used to treat a wrist fracture. Well, what do you think is going to happen? This patient is going to have severely stiff hand problems. Their MP joint's going to be terrible. Their ring finger and their small finger PIP joints are going to be terrible. They didn't respect the distal palmar, the PIP crease, or the thenar crease. So because they broke their wrist, they're going to lose the use of their hand for several months. It's absolutely unnecessary. All right, so here's what I would do. This is a custom-made orthotic. It's fit to them. Look at that, the distal palmar crease is open. They can move their fingers. Look, so their wrist fracture is healing, and lo and behold, they can move their fingers the whole time, okay? All right, so in my mind, I might be a little bit biased. Custom splinting is always far superior to off-the-shelf splints, okay? Positioning mistakes can lengthen the rehab process by months, which causes huge financial losses to the workplace, to the patient, to the carriers, to everybody, okay? Much less a patient probably not getting full hand function back when they very well could have. Not trying to brag, but our hand team, we provide our hand surgeons with a weekly splinting clinic. So basically all of our surgeons have clinic on the same day, and we do a walk-in clinic, and they send all of their patients down and we splint them. And all the other days, our surgeons have the ability to send their fracture patients down or whatever, because we have convinced them to let us position their patients correctly to prevent long-term hand stiffness, okay? And it's working out very, very well. All right, so besides positioning, what else can you do? Early referral to hand therapy, okay? And you can refer to therapy while someone's bone is healing. I know a lot of people are like, don't send them to therapy. They might hurt them. They might break their bone. Well, yeah, some people don't know what to do, but if you send them to a skilled therapist, we're not going to hurt them, okay? So it might just be one to two visits. I can assure correct positioning. If they're in a terrible splint, I'll make them a new one. Patient education, start a home exercise program. If something isn't broken, they can move it, right? So that makes their hand less stiff. So if they have a broken wrist, I can actually treat them for a broken wrist and not even have to worry about their hand, okay? I call it prehab, right? Y'all know what prehab is. Prehab can prevent weeks to months of therapy that will be needed to restore hand function. I think it's a no-brainer. All right, hand therapy, stiffness, and evaluation. Okay, I know you guys get a lot of hand therapy notes, right? Okay, those notes are specifically written for surgeons, but I know they end up on your desk a lot and you're like, what is all this stuff in here? You guys are used to range of motion, strength, and coordination. You know what all that is, right? Well, how many notes do you get that include all this specific testing, notation of specific structural tightness, okay? So I just kind of wanted to give you a synopsis of what you might see and what it means. Intrinsic tightness, common terms. Intrinsic tightness, extrinsic extensor, extrinsic flexor, joint capsular changes, and tendon adhesion. If you guys have a brief knowledge of all of that, you can go through a note and be like, oh, I know what's going on here. All right. Okay. Intrinsic tightness. Almost every hand patient has intrinsic tightness. Okay. There are these little tiny muscles that originate and insert in the hand. And they're tiny, right? They look like they would cause no problem. They absolutely cause many, many problems. If they are allowed to sit in swelling and not be able to move, they turn from a nice little muscle, a soft little muscle, to a tight fibrotic muscle that takes months to restore their length again, okay? What you will see is when someone has intrinsic tightness, you ask them to make a fist, and it'll be like Miss Smith's hand. She won't have the ability to make a fist. She'll do like the duck bill, okay? It's very, very difficult to get rid of intrinsic tightness. It's also called an abnormal intrinsic dominant pattern. All right, look at this hand. Okay, this lady had DIP fusion. So the very tip of your finger, many women get severe osteoarthritis, right? And a lot of times they have to fuse those joints for pain relief. So they fused her joints, but they immobilized her entire hand. Okay, so when I asked her to make a fist, this is what I got. My heart sank to the ground, okay? 2 DIP joints turned into an entire hand of stiffness, okay? So now we're going to extrinsic. Extrinsic means the muscles start outside of the hand, so they originate in the forearm, okay? And the extensors they are responsible for extending the wrist and the fingers. So basically they do this, okay? Tightness causes limited wrist and finger flexion. So if you're tight on the back, you're going to have a great difficulty bending your wrist, and especially a great difficulty bending your wrist and fingers together, okay? So basically here, if your joint is an extension, you can bend your finger great. It looks great, right? Then you bend that joint down a little bit, the MP joint, and their finger pops out, okay? All right, so here's a great one. This man has perfect wrist motion, right? Well, when he makes a fist, his wrist doesn't bend. That's a true case of extrinsic extensor tightness. All right. Extrinsic flexors. So basically, they're the muscles that bend your fingers and your wrist, okay? They start in your forearm and end in your fingers, okay? So if you increase extension of the wrist, you're going to lose extension of your fingers. So in this case, this young lady has really nice finger extension, but when you bend her wrist, her fingers curl. No big deal, right? Until you try to do a push-up or push up from your chair and your fingers curl underneath your hand when you're trying to push up. It's a problem. Tendon adhesion. Scar tissue adherence to skin, tendon, and bone. I told you, we're like puppets. We have to glide. Our muscle contracts, it pulls onto the tendons, and that's what produces finger motion. If you have trauma and you get scar, you're not going to glide. So if you get scar on your finger, you're not going to be able to make a fist. It's like throwing a wrench in a car engine, right? The engine isn't going to work. All right, so here's a really good example. This man had a plate put on his metacarpal, and he sat still for a really long time. So if you can see the puckering there, his scar actually adhered to his metacarpal bone, so he couldn't straighten his finger and he couldn't bend it. So that's a really severe case of extensor tendon adhesion at a postoperative metacarpal fracture fixation. All right, so traditional treatment principles like tendon gliding and going to the therapist to have stretching and strengthening, those are great in early phases, right? So you catch someone early, you get them to therapy, all the traditional therapies are fine, okay? But connective tissue has viscoelastic properties, meaning you can stretch them, you can warm them up, their hand is great. Well, guess what? It goes right back to the beginning. So the patient will say, I do my exercises, and then I go to bed and my hand is the same. So I call it the hand Groundhog Day. Y'all remember that movie when Bill Murray went to bed and every day it was the same day? It was Groundhog Day. Well, that's what our patients are going through. And they all hear from me. I'm like, oh, you're in the Groundhog Day. And they look at me like, what? And then they're like, oh, yes, it is like Groundhog Day. I do live the same day every day. So when the Groundhog Day starts happening, stretching and exercise has very little effectiveness. And then you're like, well, crap. Well, if that's not effective, then what do we do? Oh, we got more. Okay, so when you have stiffness and swelling and limited tendon glide, intrinsic and extrinsic tightness, and abnormal movement patterns, what do? Well, you have to treat them all simultaneously. Well, how in the world do you do that? Do you make 6 different splints or send them to 4 different therapists? I mean, Lord, what do we do? Changing 1 or 2 factors alone it won't fix the problem. You have to fix them all. So you have to address motion limitations early with orthotics, meaning splints, if needed, to fix the problem. Unfortunately, we get hands every day that have already developed multiple problems, okay? You know what they're called in our clinic? A train wreck, and we don't like trains. So traditional methods, they can be used initially. Like I'm saying, you can use them. Regular therapy, that's fine. But we tend to live by the earlier is better concept in our clinic. So we might apply some sort of orthotic or splint all the way to a CMMS cast. Has anybody ever heard of a CMMS cast? Anybody? Okay, good. I'm going to tell you all about it. On day 1, I might meet them day 1, and pending y'all's approval, of course. Sometimes I have to ask for forgiveness, but we might put a splint on them on the first day. So the first type of splint I'm going to talk about is a mobilization or a static progressive orthotic. So a lot of times we're going to ask you guys for approval for a static progressive orthotic. Do you guys all know what that is? Have you come across that term when therapists are asking you for approval? Maybe? Okay, anyway. So we apply a low load force over a prolonged period of time to increase range of motion, right? Okay, so it stimulates collagen realignment. So I talked about that collagen. It's abnormal, it's bunchy, it prevents your fingers from working correctly. So I'm going to try and realign it to improve joint range of motion. It's really great in the fibroblastic or the maturation phase, meaning we're getting on up there, the patient's not acute anymore, things are starting to settle in, they're starting to scar, you start making things. Traditional therapy doesn't work. All right, so a static progressive orthotic. It's a force applied in a constant manner. Guess what I use? A fishing line. Yeah, I use 60-pound test fishing line, and some days I steal it out of my husband's tackle box, and he doesn't need to know. But yeah, we use fishing line. Sometimes rubber bands, but I find them to be pretty ineffective. So we position them at or near the end range and no pain greater than 3 out of 10. The force is adjusted. So say you put the patient in, they feel a light stretch. You say, okay, Miss Smith, after you wear it for 10 minutes, if you don't have any more stretch or no more pain, pull your finger down just a little bit more. Stress relaxation occurs and the tissues elongate and cause a permanent change. So a permanent change means you're getting your patient out of the hand Groundhog Day. So shorter wear time, 3 times a day for 45 minutes. Really effective for stiffer joints, like joints that you push on and they feel hard, okay? They're not tight, they have more of a permanent change or a capsular change and they feel stiff. Disadvantage, you can get a patient that is not the right choice. They can go gung-ho and they'll say, hey, I'm gonna stretch my finger down as far as I can take it, and I'm going to have 10 out of 10 pain. Well, guess what? That'll make them worse. So make sure that the therapist that you're using is choosing the right patient to put this splint on. All right, so here, if I told you that I could make a splint out of plastic, fishing line, and a zip tie, would you believe me? Because that's what that's made out of. Plastic, splint, thermoplastic cuff. This is a fishing line. We use a releasable zip tie and we cut it off. And so when the patient pulls it down, they have a audible clicking sound, so they know that they're getting their finger down. And sometimes I'll put a little mark on there and say, hey, this is where you started. Let's see how far you can get. So they get that audible clicking. So when they pull on the bottom of this zip tie, it brings their finger down. It's pretty cool. This is one for PIP stiffness. This is someone who went into that bad TKO off the shelf price. They can't bend their MP joints. Well, guess what? They get to wear this really nice contraption where here's the cuffs, okay? And then there's their zip ties that they're going to pull down on. And as they pull down on them, it's going to stretch their fingers down. This is a really good one. So this is one to treat composite flexion. Okay, so this patient couldn't really bend their fingers at all. So I had to make a splint with 2 cuffs on each finger to bend their fingers into a composite fist. Oh, and then the reason why she got this is because she had a proximal phalanx fracture of this finger, had her whole hand immobilized at another clinic, went to therapy at a different clinic without a hand therapist. So when I got her, I had to work on the stiff joint and then the whole dang hand because she broke one of the tiniest bones in her hand and it was malpositioned while it was healing. I'm still working on her and she's looking at a surgery so that this finger will bend. All right. This was a gentleman who had a tango with a table saw, and obviously he lost his finger here. This was a replanted finger. This finger was fine. This finger had a proximal phalanx fracture and extensor tendon repair. So this finger gets a composite flexion, and then this finger has a fingertip stretcher. So we can basically make anything and everything that you might want, okay? If there's something you want your patient's hand to do and you find the right hand therapist, we can make it. All right, this person just couldn't bend the tip of your thumb. You think no big deal? Try going without good thumb movement and see how you like it. But anyway, this is just a splint to bend someone's thumb tip. This is just a splint to bend someone's small finger PIP. So there's the plastic, the fishing line, and the zip tie. This is that nasty intrinsic tightness that I told you about. This is an intrinsic tightness stretcher. Okay, yes, time. Oh, okay. So that's something cool. CMMS casting. All right, so I use cast to increase hand movement. Sounds crazy, right? I work in an orthopedic practice where you use cast to immobilize someone to heal them. I use cast to immobilize a joint that moves well and force the joints that don't move well to move more. Y'all got it? Okay. So the cool thing is, oh, and the patient, the patient completes 1 to 200 repetitions of active range of motion. So they're put in a position where I basically trap them and they can only move their fingers where they're stiff. Every hour that their eyes are open, 200 times, they do the exercise, 1 exercise instead of 10 to make their fingers move better, okay? It's very effective in a chronically stiff hand. So if you get a horrible hand and you all don't know what to do, find a hand therapist that does CMMS casting, okay? You will not be sorry. And it reduces edema because a cast is wrapped on circumferentially. All right. So like I said, they only move in the desired position. It treats joint stiffness, intrinsic tightness, extrinsic tightness, tendon problems, everything all at once. When I learned how to use this, it was an epiphany. It literally changed my game, and I'm able to help patients so much more. All right, I'll mess that. So those are all the things look at that. Your 1 cast can address all of those problems, all of them. So this patient, there's Miss Smith. She came in, that was her fist. So I put her into that cast, and I only allow her to do the opposite of what she's got. Well, looky here. She came back after about 3 days, and she'd been doing her 200 reps an hour. And look at her fingers. Do you see the difference? No more duckbill. Now she has the ability to move her fingers. And I zipped that down, I cut it, and I allowed her to be able to remove it for bathing, and she loved it. After 4 visits, that's what her hand looked like, okay? She went from a duckbill hand to a hand that would bend. This is a man that had a thumb surgery. He was immobilized for too long. His hand was a mess, a myriad of problems. I put him in here, so I only allowed him to move like this, okay? In the end, he got full hand motion back. I was able to treat about 10 problems all at once. Pretty cool. All right, why not use it more? Well, it requires a dramatic change in thinking. MDs associate immobilization in a cast with immobilization. A lot of my doctors they're like, I don't care if you do it, but I don't want to see it and I don't want to know about it. So I do it to almost all their patients, and if they don't see it and they don't know about it, all they care is that I fix their hand, and we usually do. A lot of therapists have fear of immobilizing joints because we've been taught not to, okay? Cast application and removal is very unfamiliar to US therapists. In Europe, it's more prevalent, not in the US. Most therapists don't know how to use a cast saw. Okay, I'll be honest, it was very scary for me to use a cast saw. I'm a whiz at it now, but learning that was very frightening. Anyway, so beyond the cast, I use this product. It's Lance Medical. It's the best off-the-shelf product that I've ever known. I learned about them about 11 years ago at the ASHT conference. So their product can treat wrist stiffness, finger stiffness, extrinsic tightness, extrinsic flexor tightness, extrinsic extensor tightness. There is no other product in the market. And by the way, I have no financial gain by speaking for them. I'm just talking about them because their product is far and beyond the best product on the market. So if you have a therapist that can't make all this fancy stuff that I do, at least get them into one of these Lance Medical devices. If a therapist asks you for a Lance Medical device, don't try to replace it with a different brand, because as a skilled hand therapist of over 22 years, this is the best device on the market, okay? Once again, I have no financial ties to them. All right, final thoughts. It's a team-centered approach, okay? Typical therapy is not enough, okay? Putting on splints sooner than later is better. If a therapist asks you for a splint, usually we want to put it on like that day, and we're trying to be good by asking for permission. So please, if you can, try to approve it as soon as possible so we can get the show on the road, okay? The best thing to do is prevent stiffness, okay? It is the most effective treatment. So getting your patient to the right therapist to put the right splint on, sending your patient for an early therapy referral, okay? Let's prevent all this. Let's not have to put them in a cast, okay? And do not create a mess of problems to treat one. Thank you. Does anybody have any questions? Questions, anybody? Nope. Okay, it was an honor to be here. Like I said, speaking with a bunch of surgeons and doctors and then a therapist, so I'm very honored to be here. Thanks for listening.
Thanks, Nicole.
You're welcome.
All right, our last presenters of the day, we have Jennifer Fortenberry. Jennifer is a native of Opelika, Alabama, and has resided in Huntsville since 1996. She has provided